right. I think it's time for us to start. So Dr. Ugochi and Dr. Cynthia, you can submit it while I begin because of our
I've
time.
submitted, sir.
Yes, confirm.
Okay.
I can see
I've submitted.
Dr. Ugochi.
I've submitted.
Okay. Let me just confirm from both of you. Dr. Cynthia, I've not seen your so. Dr. Cynthia, you said you submitted. Or was that Dr. Ugochi's voice?
I submitted, though.
You sent it to me.
So your line, yes.
I've not seen it. So has it been delivered from your end?
Let me check
You
it.
showed double strikes. Dr. Cynthia, please confirm that so we can move on. So, okay, yes, I just got it now. That's coming.
Sorry, I went to send to another Dr. Osazee. Sorry.
It's all right. Thank you so much. Please, moderator, is my voice audible? Am I loud enough? Am I loud enough, my moderator, ma'am?
Yes, you are, Dr. Osazee. You are.
Thank you very much. And I'm sure you can see my video as well. All right.
Yeah, there seems to be interference from the other device. It's echoing.
Okay.
Your voice is echoing. Maybe you
What
can
about
move
now?
the other one.
What about now?
I think it's better now. Say it again. Go ahead. Let's see. Let's hear you.
Is it still echoing?
A little bit, but go ahead. If it's too bad, we'll let you know.
Okay. So, I just needed it to monitor the work, so let me just mute it totally. All right, so I want to thank you all for joining again tonight. It's been a whole lot of, it's been a rigorous exercise thus far. And just like I mentioned earlier, we're looking at this by the introduction to binocular vision, one of the modules under BVD in FOM, as compared to the very bulky BVD part 2 that we are very familiar with. So this slide is shorter. This slide is about 100, and I'll try as much as I can to run through it. Where we need to discuss further, yes, we will, but where we need to move forward, we move forward. So we all know this quote in front of you here was mentioned by Helen Keller, and she said that the only thing worse than being blind is having sight without vision, or sight with no vision. So we know that's one of the three tests that I mentioned or asked us to submit, because over time, vision has been confused with sight. In fact, even in the religious setting, we know that vision is really deeper than sight, and as the professionals as it concerns vision, we should know better. Orrin Wardwood said that sight is seen with the eyes and vision is seen with the mind. So we should understand that vision is deeper, way, way deeper than sight. Sight simply talks about the ability to see. So the organ involved in sight is just the eyes. So the ability to see, but the question is what you see. Do you interpret it correctly? So imagine your day, or starting out your day, and you're not, and you're able to read a paragraph, but as the day goes by, due to visual stress, the paragraph looks almost like what you see on your screen right now. In fact, I can't look at this thing for more than 5 seconds, my eyes, becomes very, I don't know if you feel that too, because there's a lot of strain, there's a lot of effort trying to get what the words say, even if you end up, figuring out what it is, but there's some form of visual strain that you go through in able to do that. So imagine, having this kind of vision or this kind of experience as an adult. So on the top of a child that is young and of course they're at that stage, whatever they see is a great, it contributes significantly to their entirety as humans. We know that there's a very strong correlation between vision and learning. And that's why at a young age, you must ensure that your child sees as good as they should. Otherwise, their learning abilities will be truncated. It's going to affect them very seriously. 80% of what a child knows, these have been proven with literature there and there. 70 to 80% of what a child knows comes from what they see. So it will be very, very, very unfortunate if the vision of the child is not as good as it should. Imagine after reading it for a brief period, your child complains of saying something this way. Things appear ghosting, like you see in this picture, or double vision. Obviously, that child will not enjoy reading, and that would affect him or her significantly. It may even be worse when this child comes to you, and at the end of the day, you do all the tests you need to do, and the regular suspicion we may have, which may be a refractive error, has been taken out with your tests. You see that vision is very good, put at far and at near, and you do your refraction and you're getting 0, you're getting planning. So no refractive error. But this child complains of vision, of blurry vision, especially at near. Sometimes you are, taking off balance. You really don't know what to do. And in fact, this is for a fact. A larger chunk of us as eye care professionals at this point will not be able to do the next or the best, give the best to that child. We may now force the child to just wear some form of glasses, or we say the child is malingering. We've seen this a lot happen. Most of the cases that have been referred to me, most times when I interact with the doctor after I've seen the case, they will tell me that. In fact, they may even suggest that it seems that this child is malingering. I don't know what's happening. But after my examination, I will call them back. I say, "Come, that child wasn't malingering. It's exactly what's happening," because they have experienced, they have seen that there's no refractive error. But this child is saying, "I can't see at near." So when a child comes to you and that's their story, don't just shelve it and say this is a malingering child. Dig further, you definitely find a problem going on. The child that skips lines, the child that loses place when he or she reads, that may also be a problem. So these are the things we must understand and try as professionals to keep watch. All right, so very, very briefly, we're going to be looking at these 4 objectives tonight. Hopefully, we're able to cover the 4 of them, where the first will be understanding the difference between sight and vision. Then we'll also learn the classifications of binocular vision, and as well how we can diagnose accommodative and divergence disorders. We may play down on this third objective because it's a module on its own. That's the BVD part 2 that we all know. So diagnosing these conditions using all the tests we have, I may play down on it. So when we come here, I may not be very, very detailed. I will just skim over them. And of course, how to treat. So this is also, I'm also going to play down on the 4th objective because that's vision therapy itself. Okay, and we cannot finish all of these in this 2 or less than 2 hours presentation. So our focus tonight will be knowing the types of binocular vision, its function, and understanding the different things of vision. So sight vision, just like I explained earlier, an ability to see, that's what sight is. Okay, the ability for you to say, "Oh, I am seeing something." Someone stretches something towards you, you see something, you see people, you see buildings, you see cars. Now, or let me just say you see objects everywhere. Now, the question is, can you actually identify correctly what you see? If you don't have that ability to identify correctly what you see, then you may just have sight and no vision. Okay, so the interpretation part and interpreting correctly and responding accurately to what you see is all involved in vision. That is why vision is deeper than what we think. Okay, way deeper than what we think. If, for example, I have a ball, or I have a stone, let me use a stone in my hand, and maybe we are having an argument, and I take that stone and throw it at you. I know you would see the stone, your reflex is already telling you that, okay, we're already having an argument, and maybe I want to hurt you or something, and you see the stone, you see my hand up, and you see me throw something at you. Yes, you may not know if it is a stone or not, or you may see it as a stone, but the question is, how will your body move? Will you be able to move away from danger, or even move towards it, or not even move at all? So some persons are at that point where, well, you may also call this reflex or some form of skill, but trust me, these are all part of vision. That's why behavioral optometry is really a deep area of eye care. That if you go into it, it involves a whole lot. In sports, it's involved. In occupation, it's involved. Everything about it. So when we train people for some form of skills, a serious team would consider involving the behavioral optometry to be able to improve, the reflexes. Yes.
Sorry, are you changing your slide? Have you changed your slide? My screen vision.
No, I've not changed it. I'm still on sight and vision.
I don't. Okay, because it was just paused.
Yes, I'm still on sight and vision. Apologies. I'm just explaining it so that when I get there, I move on. Are we together, Dr. Cynthia?
Yes, sir. Yes, sir.
Can I go on now? All right, thank you. Okay, so I'm just trying to stress the importance of vision. So when we talk about vision, we talk about something much deeper. Okay, so we say vision involves both sides, that's the eyes. So your eyes are involved. The brain is involved because the brain is what is like the powerhouse of the entire body. Brain is involved, and of course, the entire body. So if there's a connection, good connection with the eye and the brain, and of course the brain and the body. So we're looking at both sensory and motor, processes. So whatever the eye sees, it sends it sensory to the brain, and the brain returns motor information back to the body. If all of these processes or these areas are in good shape, then the person involved, or the individual involved, will be said to have vision or good vision. Okay, so the story I gave you earlier, the scenario I painted where a stone is thrown at you and you are able to move away from the stone as quickly as possible, not to get harmed, is one way to make you pass or give you a pass that yes, you have good vision, not necessarily good reflexes, in as much as that can also be trained over time. I remember, having sessions with Dr. Echelu back then when I was working with him. You know, if you can, if you go to his vision therapy clinic, all you think is a playground for children, yes, because you see all the gadgets, there it's just it's fun basically. I know because you're a child, you're children, you want to create a fun environment. But if you look at those exercises, it's you may commonize them, but these are things that helps. All right, these are things that helps. You will see a trampoline there, where you bounce over on top of it, and you see some dancing. Some it's quite interesting. Okay, so that's what vision is. So vision is really, really, really deeper than sight. So I've already explained what vision is and what sight is. So sight is just an ability to see detailed things, and of course, it is measured as it's measured by the visual acuity methods that we all know, and that is scale of 20/20. When you say someone has 20/20 vision, you say that person has good sight, but that person may not have vision, because vision now has to do with how do you interpret things that comes to you, that comes around you. Okay? So that's a diagram that depicts sight and vision. So I've already explained all of this, so I'll just move forward. But one thing you need to take away from this slide that is in front of you is that every research have actually proven that children, a large chunk of them, say 1 in 4 or 7 in 10, have vision problems. Okay, so and just like I mentioned from the very beginning, a child that lacks good vision will not be interested in learning. And most of them will go into social vices, because that's being in the school would be something that is alien to them. And it's not their fault, with my little experience with these children, you would find out that most of them really don't have, they have a zeal to learn, but they just can't. So they do the things that are more convenient for them. So they can't sit down with a book. Rather, they go out there to play, because things at distance appears clearer to them. But as soon as they bring the book near to their eyes, vision is gone. They can't interpret correctly what they see, and so they find interest in things out there, and that opens up that child to become whatever the society wants them to be, because that's where they find more time to be. Okay, children with 20/20 vision eyesight may also be able to see distance. All right, so this is two ways. The first scenario was that children that can't read will end up going out, because that's what they do more, and that's what they enjoy doing. But conversely, you can also have a flip of that, where when children go out, they can't see things at distance. So I don't really believe, although this is a personal thing, I don't really believe that any child is born to be introverted. In as much as sometimes genes and genetic manipulations can play roles, but if a child have the right exposure, they may not see too much, but the idea of being introverted, being on your own, wanting to always be indoors, it's not it, because every child wants to play, every child wants to explore. But when they go out there and each time they look at things afar off, it blurs out. They don't make sense of things afar off. So they wouldn't want to be there. And in this kind of generation where if you go out there, maybe for example, you're told in school you want to play sports and you want to kick a ball, you try several times, you miss the ball, you kick the air instead of kicking the ball, and your friends tease you, laugh at you, bully you. These are factors that will push that child inward or inside. And before you know it, the child becomes, they call them nerds. they always read their books because that's what they see. All right. So I don't believe if those things are neat on the board earlier, a child should have a good mix of both the indoor experience and the outdoor experience. And so these are the things that we should
Sorry,
take
Dr.
into.
Can I see the previous slide, if you don't mind?
Did you see this?
No, the previous slide, not this one.
What exactly are we looking for? So this is introduction. This is the slide I discussed about
No, I
children.
think the slide before this one. There was a slide that explains site. The slide that explains site. Yeah, I think the one before this one. Yes, okay. Okay.
Are you good?
Yeah, that's okay. Thank you.
All right. So I've explained two scenarios. Okay? Now we must pay attention as eye care professionals. We must pay attention to these scenarios. A child should have a mix of both the indoor and the outdoor experience. If you see a child always going out, then something is wrong at near most of the times. And if you see a child always indoors, something is wrong at distance. We must pay attention to it. Most of the times, teachers or parents believe that this child is suffering from ADHD. Yes, there's a possibility of that. Every child, like I mentioned earlier, is hyperactive. Every child wants to play. They want to have fun. They want to scatter the whole place. It's in their nature, but we shouldn't believe that every hyperactiveness is due to this disease condition, where it has to do with the mental. If we have nipped it on the board, maybe we've identified a vision problem, it's easier to help that child, right? So I've mentioned that there's a lot of children that have this condition. So 15 out of I'm sorry, my second device has gone out. That's where I present my slide with. I beg your pardon. It's coming back on again. Can someone hear me?
Yes, we can hear you clearly.
Okay.
But we can't see your slide yet.
We can't see you on the slide.
We can see him now.
From my end, I can't see him.
Okay.
Yes, he just came on and disappeared again.
Let us see and using the video. So we may find with this. All right.
Okay. I think we need to give him some minutes. He's trying to fix himself. Okay, he's back. Hello, Dr. Osazee. Okay. Hello. I think Dr. Osazee is having some network challenges. He's trying to reconnect back to the platform.
Hello, Doctor. Can you hear me, please?
Okay, we can hear you now, though breaking.
hear me? The network is really crazy, so I'm outside the house.
Hello, Dr. Osazee. I don't think we can hear you.
Hello, Dr. Erikachi, can you hear me? You can't hear me.
We can hear you now, Dr. Osazee. Hello? Hello, Dr. Osazee. Please, let's exercise a little patience. I think he's trying to fix himself. The network is very poor from his end. Okay, so please, let's wait for Dr. Osazee. Like I said before, he's trying to fix himself owing to the poor network from his end. So we might need to. Hello, Dr. Osazee, are you back? Might need to give him some time. Maybe let's see if the network will be stable. Just hang on and wait. Okay.
Dr. Edikachi, can you hear me now?
Yes, we can hear you now.
Okay. Please, I really apologize for this. Sometimes you don't know what, although we have a generally poor network here, but sometimes it could be good enough. So I'll just limit myself to where I am now. I'm actually outside the house, so pardon the background noise you hear. So I'll also just share my screen very quickly. Can you see my screen, please?
Not yet. Okay.
All right. So just quickly go to where we stopped. Can you see the screen now, Dr. Edikachi?
Not yet. Okay, yes, we can, but as a PowerPoint.
Okay, yes. So I would okay. So I'm sure you can see it fully now.
Not fully. It's a blank screen. I'm not seeing anything there.
Okay. But you can see other things on the screen. Let me just restart. We pick. Can you still see my screen?
Yes, we can see other things, not the slide.
All right. Let me just try and get the. Let me get the file again. So I promise I'll end this lecture. I won't go beyond the time. So I'll just try as much as I can to summarize some of these things. I'm sure we all are familiar with what we're talking about here. Okay, so please confirm if you can see my slide now.
Okay, yes, we can.
All right, thank you very much. Once again, apologies. So I permit me to turn off my video because of the low bandwidth of network. And I'm just going to be using one device. Apologies. So I was actually on this slide talking about the fact that most of the children we see with some form of attention deficit hyperactive disorder had some visual problems as an undertone, and we shouldn't shy away from that. I believe that if we have acted earlier, or if that child had seen, because it can be two-way, it can be the fact that the child or the guardian of that child, chose not to see an eye care professional early on time, or they came in and saw the professional, but the professional did not detect it on time. So it can come from both ways, but whichever ways, we must ensure that this is tackled. So we have already explained all what vision is about. You understanding, seeing something and understanding, deriving meaning from what you see and react correctly to what you see. Sometimes you react wrongly to what we see. That also shows that there's a problem with vision. Vision involves movement of the eye, fixation, accommodation, divergence, trimming of the eye. Yes, eye, brain, and hand coordination, visual perception, and of course, some other tiny little things that we overlook, integrating visual motor integration. Okay, where we talk about pursuit, we'll talk about circuits. We discussed a bit of it yesterday, where we talk about motion sickness, how it has a combination of both the auditory and the visual system, a lack of proper interpretation of stimulus coming from these or stimuli coming from these two very important systems of the human being. All right, so all of those things is involved in vision. That is why I prefer to stand on the visual concern or the visual aspect of that. Um, Vision also means judging relative speeds. Now you see sometimes this is very peculiar with drivers. A couple of times when I'm on the road, you're in a traffic and all of a sudden you just hear boom behind you. A car has hit your bumper and you're wondering, are you not seeing? It's actually a traffic, a slow drive. You're not even moving fast. So how come, but with my understanding, just know that maybe this person is not seeing, he or she lacks vision and they lack the ability to judge space, depth in position, the exact position, in space. And this is very typical, particularly where a patient is having glaucoma at an advanced stage, because we know that stereotypes at that point drops. Okay, so you see patients can't judge steps, they can't judge heights, it's very, very difficult for them. And so it's something that we must put into consideration. Vision also involves that. Vision talks about, the ability to swing the baseball bat. So you could see all the processes involved here. Swinging the baseball bat, you're seeing the ball, it's coming towards you. How much can you judge that this ball is already close to you, and how much can you swing that bat to ensure that that bat touches the ball? And of course, when you touch the ball, you hit the ball, you have to run. So there's a lot of processes, a lot of things involved in that process. So it's all part of vision. As primary eye care providers, we play vital role in ensuring that we improve the visual status or the vision of every patient that comes our way, especially for young children. I've stressed earlier that there's a very strong correlation between the vision and learning problems. Okay, every child that has some form of academic struggle, most likely may have had, problem with vision. And it's not just only peculiar to children, even adults. But if you trace correctly, you see that some of them have some binocular vision problems. So we already know what vision and sight is. So we'll just do a quick play, as this slide calls it. Color vision. What kind of vision is that? It's actually a vision problem. Myopia is a sight problem, presbyopia is a sight problem, occlusive vision dysfunction is a vision problem, astigmatism is a sight problem, strabismus is a vision problem, obviously, amblyopia is a vision problem, binocular vision problem is a vision problem, and of course, hyperopia is a sight problem. So I'm sure we also know the difference between binocular vision and biocular vision.
Sorry,
Please, am I still being heard?
Go back again once. Sorry, just a moment. The color vision, what did you say it is?
The color vision is a vision problem. The reason is because it has to do with interpreting. Okay, some persons may see blue and call it black. They may see red and call it purple. Although, like we said, there may be other things, other factors involved here, because with the knowledge we have, we know that the color vision problem may be due to deficient, cone cells or some form of deprivation, and the cone cells did not develop properly as they should, and that could make one miss vision or miss colors. But from that explanation or from that definition, it could also, because you are interpreting wrongly, you are seeing a color. It's not that you're not seeing a color. You're seeing something, but you call it something else. And that's why we put it as a vision problem. I don't know if that answers any questions that may arise.
Go ahead. Thank you.
All right, sir. Okay, so binocular vision, like I said, the N is very, very important. It differentiates these two terms, biocular and binocular. It's a term that most of us as mentors know. Binocular, yeah, both of them actually involve both eyes. Okay, both eyes are involved in biocular vision and in binocular vision. However, in binocular vision, fusion is very key. Fusion is involved. Okay, so for you to say someone have binocular vision, it means both eyes are seeing one image. All right, but in binocular vision, necessarily fusion may not be there. In fact, the idea is that you deliberately want fusion to be absent. So one eye sees something, the other eye sees something else, and that can easily be done by putting, by putting a septum in front of the eye, in the mid-range of the patient's face. So this eye sees something else, this eye sees something else. We do that a lot in visual therapy, particularly with some equipment like the stereoscope, where one eye is seeing the plate and the other eye is seeing what you write. So that's a binocular vision scenario. But when both eyes are involved and there's single binocular vision or there's fusion, then we call that binocular vision. I hope that is clear. So if you have binocular vision, apologies for that, that's an error. If you have binocular vision, or if we understand what binocular vision is, or no, we understand what vision is, and we understand binocular, so both eyes are involved. So binocular vision is simply the use of both eyes to have, clear image, to ensure correct interpretation of what we see and all of what we have said before. Now, any challenge with that process, any form of hitch along that line is defined as binocular vision dysfunction. So they may not be very exact words. This is the simplest way to put it. When you don't have binocular vision, or when the process of binocular vision is not complete, then you may call that, or that would be a binocular vision dysfunction. So we've already known what binocular vision is, so let me skip that. And we'll say that when there is a lack of what binocular vision entails, okay, when there's a lack of it, when there's a shortage, when there's a hitch, when there's a break, when there's something wrong with that process, no matter how minute it is, because the vision process is so complex, and well, for a lack of a better word, it's so aligned that if there's any form of malignment, that may be a big deal. And it's our duty to find out where the problem is coming from as eye care practitioners. So whatever you see that negates the normal process or mitigates the normal process of vision, as we have explained prior, that will be regarded, or that could be regarded, as binocular vision dysfunction, or you can also call it binocular vision disorder. So what are the causes? What are the causes of binocular vision? Sorry. So what are the causes of binocular vision dysfunction? I'll just run through them. There are quite a number of them. These are just a few. So we say when there's near point stress due to prolonged near tasks, that could cause some form of binocular vision. And that is why we usually advise you take breaks, particularly when you are reading, because The reading process in itself involves a whole lot of things. Okay, there's convergence, the oculomotor processes as it concerns pursuit, tracking, there's accommodation, which is very, very, very important in apnea or apnea work, and several other systems. So if you do it for too long, then you can cause some form of problem. There may be some form of spasm, that may be because of too much stimulation. And of course, when there's poor general health, when your body is not fine, of course, the eyes and the visual process would also not be good. Sometimes it could be due to some form of medications that we take. Every medication has a side effect. I'm sure we all know that. And some of them could cause you some form of binocular vision problems. When there's high degree of long-sightedness, I'm sure we know why we say long-sightedness here. That's hyperopia. We all know that hyperopes are the ones that usually do the accommodation. They accommodate a lot, and that's because the focal point is behind the eye. Okay, so a hyperopic eye is also known as a minus eye. Minus in the sense that it does not have enough divergence or enough converging power. It's short of converging power, and that's why the image is focused behind the eye. Okay, so the eye naturally, or the visual system naturally, will want to increase its dioptric power or its convergence power by ensuring that accommodation takes that space. So accommodation is instilled or it's stimulated to increase the dioptric power of the eye to push that image that is focused at the back of the eye on the retina. And if that is not achieved, the brain will continue to do that because the brain is wired to always give you comfort. It's wired until I get this patient to get comfort or to see, it will not rest. It will keep doing all of that. Okay. The only time it gives up is when it has seen that this I can't do. And that's why sometimes in amblyopia or in strabismus, the brain has tried to fuse images and cannot. It just allows it to be. But it must ensure it does that. So that's why we said long-sightedness. And of course, refractive errors are seen in anisometropia. I don't need to explain this, where you have unequal refractive errors. The brain will try, like I said earlier, will try its best to see how it could merge, because when you have anisometropia and you correct the anisometropia, maybe with -1 and the other eye is -8, the brain can't fuse that image because the total magnification that will be in both eyes will be different. Okay, and so the brain tries initially to combine them. If it cannot, that's a big problem for the brain. So what the brain does is that instead of having diplopia or having confusion as in terms of what you see, it shuts one eye out, and that's also a problem on its own. Of course, nystagmus, this has to do with now pursuit, or saccades, as it were. Jerky movement of the eye, the brain is confused. Where am I looking at? And all of that. That's also a cause of binocular vision problems. Deviation, especially esotropia. We'll say eso because we have more convergence problem as compared to divergence problem. We'll look at that when we go into the binocular vision problems themselves. And of course, CP as the cerebral palsy. How do you treat it? Generally, we treat with spectacles for close work and vision therapy itself. Now, these are the classifications. First is classification, accommodative dysfunction. We all know that is classified under binocular vision dysfunction. Convergence dysfunction is also another classification. Amblyopia. This was recently, although the recently now, yeah, should be about 5 years ago, or thereabout. Because prior to that time, amblyopia was treated on its own. It's different. It wasn't associated with binocular vision problems. I remember back then in school, thinking about, or what we're taught about amblyopia is totally different from what it is today. So when you see amblyopia, what you think of amblyopia, think of it as a binocular vision problem, because and that is true. I have treated a few cases and I know that it is true. Okay, so it's part of binocular vision problems. Of course, oculomotor vision dysfunction is part of it. And lastly, strabismus. We may not be able to look at all of this in this slide or in this module. It's beyond the scope of this module. But so we're going to be focusing on just accommodative and convergence dysfunction. Other ones may be treated in the future. So from here, I'll be rushing. I'll just, I see because we don't have time anymore. I just have about 20 or so minutes to stop this presentation so we can have questions and discuss. So I'm going to be looking at the accommodative problem. Because just like I said from the beginning of this class, what are you diagnosing? You must know it. If you say this is, I'm using, I'm using wider tests to diagnose typhoid, you must know what typhoid is about. Or I'm using ELISA to diagnose HIV. You must know what HIV is, what the cells look like, so that when you view it under the microscope in the lab, you know, oh, this is HIV virus. Oh, no, this is not the HIV virus. This is maybe a flu. You should be able to know it. And that's the essence of this module. Before we diagnose the case, let us know what it's about. So we're going to be looking at the accommodative problems, the accommodative and the divergence disorders. And after that, we'll end this class. So I'll just rush through them. Like I said, we'll not be focusing on management. So please pardon us. We'll not focus on diagnosis also. So anything that talks about diagnosis or management here, I will skip. Please pardon me. All right. So accommodative dysfunction, we all know what accommodation is. A simple process that is usually stimulated at near. All right. Though we have other accompanying systems like your convergence system and your meiosis that is associated with, we call that cytokinetic response or the near triad. So it's actually a sensory and a neuromuscular anomaly whereby there's a deficiency in the process of accommodation. You can't focus clearly on objects, particularly at near, but sometimes relaxing accommodation is also part of it. So if you can't relax accommodation, it's a problem. If you can't stimulate accommodation, it's a problem. If you can't maintain accommodation, it's a problem. Because sometimes you may have enough. If you don't have enough of it, okay, maybe you don't have it at all. It's also a problem. But sometimes you can have it, all right, but you don't know how to stimulate it. You don't know how to. So anything, like I mentioned earlier, any problem or any hitch in the process of these systems can be regarded as a dysfunction. So we're going to be looking at some of them, okay? I'll just quickly mention them. Permit me to skip some of these things so that we meet our time. Okay, another thing I need to mention, as this slide just reminded me of it, is that most of the binocular vision problems, and this is, I'm not talking about what I've read, I'm talking about experience. And for some of us that have been seeing binocular visual cases, you would agree with me that most of the binocular vision problems usually have the same symptoms, most of them, okay? And that's what this slide also portrays. As you look at the symptoms now, not signs, the symptoms are usually similar. The only thing you use to differentiate them is the sign. What you as the practitioner have been able to identify in this patient. What test did you perform to say, okay, because I see this, this is that. Because I did not see that, this is not that. So your differentials is strongly dependent on the signs that comes out of it. So just know that the symptoms are the same for most of them, for all the binocular vision problems. So I'll just run through them. Fatigue, eye strain, headaches, blurred vision at near, diplopia, poor attention, comprehension problems, difficulty at close work, losing speed, fatigue, sleepiness, all of these, in as much as some may be peculiar to some, all right? So you may, for example, if I see someone coming with a hair tilt, okay, I try to, push, adjust the head again, but unconsciously the patient tilts his head. It points to his, there's most likely that there's a vertical problem, there's vertical deviation there, okay? So in as much as some of these things may interplay, but this is actually a sign, it's not even a symptom, because from our definition in school, sign is what, the practitioner or the doctor sees, and symptom is what the patient presents with. Okay, so So you may find a mix of both signs and symptoms in what I just mentioned. So let's move on. Diagnosis, like I said, I would play down on this, but you could do your case history. Just like we always say, case history is like the key to diagnosing. In fact, if you do a proper case history, 50% of the work is done. Okay. And there are questions you need to ask, particularly as it concerns binocular vision problem. And some of them are here. So I've just gone through, I'll just keep that, please pardon me. I hope you can still hear me, please. I'm not talking all by myself. Please, can someone confirm?
We can hear you.
So,
we can hear you.
Thank you so much, ma'am. So I'll mention all of these symptoms. So let's just quickly move. Let's quickly move. These are other tests you can perform, to determine binocular vision. So let's move on. Please, we'll have time to look at all these tests one by one, because I know this is the crux of the matter. The diagnosis and management. That is all the tests we perform, diagnose, and then vision therapy. Please permit me to move further or move away from this. If I discuss them one by one, we won't leave here even till tomorrow. So let's just focus on the types of accommodative problems that we have. Sorry, I just want to get there very quickly. Very good. So we have the type. I'll just quickly explain them first, then I'll of course run through the slides or skip the slides as it were. I told you earlier that for accommodation, anything, you can have accommodation, you may not have it. So if I have accommodation, then I am fine. But if I don't have it, if I don't have enough of it, because we all know that from the process of accommodation, we all know that age affects accommodation, and that is why in people that are 40 and above, they are not able to accommodate as they should. Okay, we call that presbyopia, when there's some form of sclerosing of the lens, or hardness of the lens, and accommodation is impaired. All right. So that's one type of accommodation. So it's age related. All right. So based on the age you are, you should have some level of accommodation. All right. Now, if the accommodation you should have at that age is less than what you should have, then that's a problem. It means that there are some things you will not be able to comprehend, particularly when you read or the work near work. We call that kind of accommodation or accommodative dysfunction as accommodative insufficiency, as the word implies, insufficient. You don't have enough of it. All right. And there are critical signs you use to make such diagnosis. You don't just binocular vision diagnosis or binocular vision dysfunction. You don't just diagnose them without certain strong arguments. And I think that applies to all forms of disease, health conditions, that you must have some form of evidence or some form of stronghold to say this is why I call this stuff. And one of these for accommodative insufficiency, is when you don't have enough of it. So your A of A is low, amplitude of accommodation is low. So you don't have enough of it. So we'll call that insufficient accommodation. Another type is the excess. Now this time around you have it, but it is too much for your age. This is very, very, very common with young children. That's one of the reasons why we do cycloplegic refraction, to see how we reduce the excessiveness of their accommodative status. That helps us to unmask the hidden errors that this excessive activity of accommodation, covers. So when you take that accommodation out temporarily, you are able to uncover the hidden or latent refractive error that they have. So when you have excess of it, it will show also in your amplitude of accommodation and some other tests that I don't want to mention now, but because of our time. Then for infertility, now you have it. Okay, let me just mention some of the symptoms that this patient will have, so that when I we may not be able to talk about it in detail. For the insufficiency, you don't have it, right? So When pain comes to you, you can't see. The likes of our geriatric patients that are here understand this. You can't read anything without their glasses. Okay, so they don't see things at near. But we're not looking at presbyopia now. These are young people that are still within um, their pre-presby. But you see, they can't read things at near. But they could do well at distance. They can't see things at near. That's a problem. It's a big deal. Okay. So when the patient gives you that chief complaint, then your mind should be looking at accommodative insufficiency. While they tell you that, oh, when I read for some time, after a few minutes, things just appear double or things become very blurry. Your mind should look at something else. No, they have accommodation, but maybe they have it in excess. And so when you do your tests, you'll find out that A of A is usually high for such a patient. Now, accommodative infertility now is slightly different. You have A of A, you may have the adequate amount, your amplitude may be maybe good enough, but this time around, you cannot flex it. You cannot flex, the accommodation. You cannot make use of it. Facility here also talks about flexibility. How can you use it based on the demand or the task ahead? Focusing at distance, we know that accommodation should relax. While when you bring print close, accommodation should be stimulated. Now, does the system or the accommodative system, can it do that? Can it focus clearly at near? And when you change gaze from near to far, can it relax immediately? So patients that come to you and say, oh, when I am reading, since I don't have problem reading, so I'm reading as long as my eyes on that book for the next 10 minutes, I will see clearly. But immediately I change gaze, someone calls my attention and I look away from that book. To see that person will be a bit difficult. For some time, vision will blow out. But when I now stress and focus more, I will see. But if I change again from that distance to my near, try to read again, it's also a problem. That's infertility. It's straightforward. You can't miss that at all. All right. And of course, they would usually say the flipper test, but they may have good enough accommodation. But when you do your flipper test, they will fail it because they cannot flex accommodation. And also, here you may also have some form of lag. So, because there's a delay, in accommodative response. Another one is your ill sustained, I believe. Yes, ill sustained accommodation. Now, this one, just like the word is, ill sustained. So a patient cannot sustain accommodation. They have it, but they cannot sustain it. Now, don't confuse it from excess. Excess is that they have it, but because of the excessive nature, there's what we call spasm. The muscle becomes static, and that makes vision, blurry. For this case, the accommodation is there, but it cannot be sustained. So after some time, it relaxes on its own without a stimulus or a response. A stimulus to that. It just relaxes on its own because you don't have enough power. The system doesn't have enough power to maintain accommodation. So you can see the dynamics involved in accommodative dysfunction. All right. And lastly, we have paralysis. Here, there is total shutdown. Okay, there's total shutdown of the system, either due to age or due to some form of toxicity or due to some form of neuropathy. All right. So, because of course, that the accommodation is stimulated, via parasympathetic stimulation of the nervous system with the help of the oculomotor nerve. So, if that pathway is interrupted by any means, it could also be temporary when you use psychophagics to um, reduce the effects of accommodation. All right, so I've explained all accommodative problems. So that's the idea. So you know the condition, and that's the focus of this meeting. Sorry, I hope you can still see my slide. I don't know why it vanished. Okay. So I will just move as well. Already explained all of this. Okay. So here they were just talking about the signs and symptoms, which I told you earlier. It's usually the same as myopia, all the things we mentioned before. So here I mentioned there's usually reduced amplitude of accommodation and insufficiency. Now, also take note, this is also backed up with evidence. Most times when we diagnose accommodative insufficiency, you would always see some form of convergence insufficiency. They go hand in hand. Okay, so when you're doing your accommodative test and your convergence test or your divergence test, you will see that MPC is usually reduced in those that patients with accommodative insufficiency, or vice versa. If it's accommodative insufficiency you're looking at, you may have some form of, accommodative insufficiency. So they go hand in hand. You hardly see each of them standing on their own. Why? Because they usually occur together. So don't be surprised when you see, and most importantly, because it's associated with convergent insufficiency, you may be finding some form of exo, significant exo at far greater than exo at near, as seen in convergent insufficiency. So I don't want to talk about all of these. Let's move on very quickly. So these are the tests you can use to diagnose them. We'll look at them much more in the diagnostic test for binocular vision dysfunction. So I want to quickly run to convergence dysfunction so that we can close for tonight. So vision therapy, of course, is what is used to train this. And of course, plus lenses, usually not minus lenses. Plus lenses is used to address accommodation of all of them, all the accommodative problems. Usually give ads, okay, to see how because remember, plus lenses does what is simulate, SIMULATE, they simulate accommodation. So they help accommodation. They try to replace accommodation. So when you don't have it, or when you have it but you can't manage it, plus lens would always help in that. So plus lens, vision therapy, but of course take note that if there is a refractive error, that must first of all be addressed. I don't know why this thing is so large. Okay, so this is the last one. Okay, we don't have time. I'd have loved us to do a little bit of play, but let's just skip this. Let's keep this. Good. So convergence dysfunction. So after now, we'll close. The time is, I have about 10 minutes to wrap up. Now, just like I did in oculomotor, in accommodative disruption, that's exactly what I'm going to do. But before we go into the convergence dysfunction proper, there are also some other areas, just like we mentioned. There are oculomotor skills. The ability for you to exert on a stationary object while you're in motion. Okay, you may be walking and you're looking at something. It's not as easy it's not, sometimes it's not easy for some people. They have to stop. For example, if you are reading a signpost now, some persons have to stop before they read what is on that signpost. But because they will have very good tracking system, think, oh, it's normal. No, some persons may have that. I think in time past, I've seen a few patients that tells you that's one of their problems. Okay, that's when I was still very, very young optometrist. I really don't know what was done for them. But most of the time, it's masked under, you uncover all of this when you're actually doing the vision therapy procedure themselves. Maybe you diagnose convergent insufficiency or accommodative insufficiency, and you are carrying out the vision therapy process. You observe that this person cannot track. You observe that this person cannot, move with objects. Saccades is poor. You have to now start building on that again. So these skills are very important. One, the pursuit system. So the ability to maintain a steady gaze on a moving object. The ability to maintain a steady gaze on a moving object. Okay. Okay, I think I flipped this around yesterday. I beg your pardon. I was talking about you moving and having a gaze on a steady object. Okay. I beg your pardon. So pardon me for that mix up. So the pursuit system is actually maintaining steady gaze on a moving object.
Okay, so you are pursuing the object. Let's use that to always remember. You are using your eye to pursue the image. So the image is moving around or is moving and you are pursuing it. Okay, so if you can do that, then you are you have good posture system. While saccades, on the other hand, is the ability to have successive jumps, quick jumps from one object to the other. You know, can you move? Can you jump from this place fast to the other one? And I think this is when you are moving, because if you're moving and you images are also moving alongside, right? So um, it's like a paradoxical here now. Okay, so it explains when the image is not moving, you are the one moving, but to your brain, it seems as if, you know, the brain and the object is moving. Okay, so how can you move from one object to another? That's what we call saccade or saccade system. Very, very important to convergence or to the entire visual system itself, or vision, like we call it. And of course, the divergence system, like we said, so we're going to be looking at the problems of divergence. The divergence disorders, there are about 8 of them. A few of them here are not very common, but they exist. Okay, but the most common one is convergence insufficiency and convergence excess. But divergence insufficiency and divergence excess is a bit not very common, and of course the other ones are way, way, way less common than the first 4. Okay, so in convergence insufficiency, this is very clear. You don't have enough convergence. You don't have convergence means the eye is moving in. Okay, while divergence is moving out. And one thing you should take away from here is that convergence problems are usually at near, and divergence problems are usually at far. If a patient comes and tell you that when I read, I can't see things clearly, your mind should not go to a divergence problem at all. But when they come and tell you that, when I'm looking at distance, I see things double. Because, of course, your case history, if they tell you, I have double vision, you must ask where. Is it at far or near? Right? So that helps you to, it narrows your mind to whether it's divergence or convergence problem. So for convergence of insufficiency, they don't have enough divergence at near. All right. And the striking sign here is that when you do your Fourier test, you see that you have more exo, because exo means the eyes are out. Okay, so if the eyes are out, you have more exo at distance compared to near. Or even sometimes when you have more exo at near compared to distance. Okay, but remember I showed you that the problem here is at near. So anytime you have a near problem, then it's a convergence problem. So usually exo is so high at near compared to distance. We call that a convergence problem or a convergence sufficiency. Okay. And of course, you could use other forms of, here you could have low ACA, because that's the accommodative convergence per one data of accommodation. How much of the accommodative convergence is stimulated per one data of accommodation? Okay, that could also be low here. MPC obviously is low here. Low means it's receded. Okay. Sometimes that term is very confusing. Oh, what is receded MPC? What is low MPC? Receded MPC is when it is far away from you. So having values like 16/20, that's a poor MPC. Very, very bad. So that person has very, very, very low MPC, as it were, or receded or remote MPC. While for excess is the other way. Okay, so you're having too much of this, okay, and it reflects in you having less exo at near compared to distance, okay. For divergence, like I said earlier, divergence talks about distance, okay. So when you're having divergence insufficiency now, so you're having too much of ISO, all right, too much of ISO, where you're supposed to be having too much of ISO at distance, all right, that causes divergence problem, divergence insufficiency. And when you're having the excess now, is you having too little of it. Or what am I saying? The insufficiency is too little of it. The excess is too much of it. I beg your pardon. Then in basic, I'm sorry, I have to close now so that we can, I'm trying to rush. For basic schizophrenia just talks about you have equal amount of issue both at distance and at near. Remember yesterday we talked about results. We're not looking at results here, okay? So you're having the same amount of ISO. Not that you have one at auto and the other one at auto. That's not what we're talking about. You have ISO, maybe for example, 3 ISO at near, and you're having exactly 3 ISO at far. And this patient is having some concern. Okay, this is basic isophoria. And basic exophoria is when you're having the same amount of exo at near and at distance. Then, of course, your vagal dysfunction is when you're not having enough reserves. Okay, you may, I'm sure we all know that there are normal values for your PFV, your positive and negative functional groups, your basal, basal vagens. Okay, you have normal values. So when you have too less of it or too much of it, then that could be a functional vagal dysfunction. It's not very common, but it's a problem. And of course, lastly, vertical phoria. Vertical phoria is very, very it's very disturbing. Why? Because you see, there's a patient I saw as an adult, as a something-year-old patient. He sees double, and when I gave him prisms, he has both horizontal and vertical phoria. Because when I gave him prisms to bring the images together horizontally, he saw the two aligned, but they were like the bottom of the shirt. So one was slightly above the other, and I had to also introduce a vertical prism to ensure that these two images fuse. So you can have that minute vertical phoria can be a big problem for the patient. You may correct the horizontal, but vertical, as small as it is, can be a big deal for the patient. And sometimes to help themselves, to see themselves, tilting their head, just to ensure that that error is addressed. All right, so that's all for Vagens problems. Because of our time, I think I'll just let's look at the very last slide here, and we can call it a man. I beg your pardon. Permit me that I was so fast. So of course you all know that the treatment for these two conditions, either it is Vagens or accommodation, is same. If there's a refractive error, correct the spectacles or the contact and whatever you want to do, and of course do vision therapy. But there are times where vision therapy may not help you. Vision therapy is always best when the children or the patient is still very young, when neuroplasticity is still in place. You could change, remember we said it's about the eye-brain-body coordination. So when the brain is still, it has to be malleable, for lack of a better word. You can still train, you can still condition the brain to learn. Okay, then it's easier. However, recent studies have there's a lot of work actually going on in trying to remove that factor of neuroplasticity in terms of treatment of amblyopia. Because we always say that, in fact, when I left school then, they said amblyopia cannot be treated. But of course, they are correct actually, because they believe that at a certain age, your brain is already used to used to the laziness of one eye. And of course, it cannot interact with that eye anymore. However, there is a lot of research going on, and we are actually proven that there's a light, ahead of the tunnel in that regard. And so let us be very, very, I have also seen that firsthand, because I have treated the patient of amblyopia and vision improved in that child. Though the child is not very young, around 15, 16 years old, I would still say that child is still a bit young, but there's always light ahead of the tunnel. Even in adults, research is saying that you can actually treat, amblyopia, or cases that you think because of neuroplasticity you can't do anything for that child or for that patient. But there's a lot of advances going on in that regard. So what's the take-home advice? More than 30% of all patients we see have binocular vision, and it's important we properly screen for it. In fact, I would increase this. It may be anecdotal, you may not find, I may not have evidence to back this up, but I will tell you that 60 to 70% of the refractive cases you find in children, if not more, there is usually an associated binocular vision problem. Okay, so I narrowed this statistic down to children, and I know that those children that have refractive errors, you may find 60 to 70% of them having associated binocular vision problem. So your knowledge of binocular vision is paramount in successful VT practice. Add VT to your practice, although we didn't talk about VT much here, but that's just a wake-up call for some of us. Even if you're not a specialist in that, or you're a contact lens specialist, you can identify these conditions and refer appropriately to those who can do it. So I think I will just stop here. Thank you very much, and God bless you all.
Okay, thank you, Dr. Osazee. Thank you very much. That was a brilliant presentation. Okay, please, we need to react. Any question, input to this presentation?
Okay,
please, questions.
I have.
Oh, okay, go ahead.
Okay, good evening, everybody. Thank you very much, Dr. Osazee. The lecture was very fast. We'll have to revisit topic. Although we still, I believe, I learned a lot, and I think other people learned too. So, but we still have to revisit this one, maybe later future or something. So, but I wanted to ask, apart from plus lenses for accommodative problems, is there any other? Is there a training? Is there a training for patients with accommodative problems?
Okay. Is there a training that's
yes? Apart from giving plus lens patients to correct accommodative anomaly, training for helping them like with these accommodative problems. I know the plus and minus lens. So what do you call it again? Plus or minus lens something. But
yeah, you know
the accommodation.
Okay. Yes. To answer your question, there are a few vision therapy exercises. If that's the question you're asking, vision therapy exercises for accommodative problems. Am I correct, though?
Yes, you're correct.
There are quite a number of them, and we have slides in that regard. So I'll just mention a few of them, from my head now. You mentioned some already. You have the accommodative rock, okay, where you use your plus minus lenses, right? To try and stimulate accommodation. And of course, you build it there in stages. First of all, you build amplitude, and later you go on to make them a bit more formidable, sustaining them. And later on, you go and build try to also build facility. That's one. And there are types of them. We also have what we call lens sorting. Lens sorting, the ability for you to be able to arrange lenses in terms of increasing power, both in plus and minus. So you give it a couple of lenses to patients and let them look through it while they read and tell you, okay, it magnified it in this side, this one magnified it lesser or more, and they are able to arrange them in increasing or decreasing order as the case may be. And that's also another way to treat accommodative problem. We have your accommodative flipper lens. Flipper lens also helps you to train accommodation, okay, especially for facility problems. You can use that to train them and you increase the power as you move forward. Then there's another one that I like so much, and I have some special interest for it because it does a whole lot. And I will call it the heart charts, both at the standard and here. That does a whole lot. It trains for teaming, tracking, speed. It does a whole lot once and for all. Okay, so it involves you having a couple of letters at near and also at far. All right, and the person interchanges between distance and near, reading each line. And there's a systematic way you actually administer that therapy. So these are a few of them. There are quite a number of them that you have, but yes, To answer your question, there are exercises outside plus lenses that you can use to treat accommodative problems. I'll just stop there for now.
Okay, thank you
I
very
hope
much. But I have actually tried the lens rock, yes, accommodative rock before, and I know that within my mind, I know that I just did that thing, but I don't know whether it worked or not. But I don't know if you have been doing it, does it work? Does all this all training they actually work?
Well, if I would say, of course, it works. I may not have seen enough patients to be very authoritative in that regard because you must, for you to, maybe the likes of Dr. Chendu and co that have seen hundreds of patients, that have these conditions will authoritatively tell you yes. But outside that, from research, from the little experience I've had, yes, it does. One thing you should know about vision therapy, it's not something that you rush and do. It requires patience. And I think that's one of the reasons why a lot of us run away from it. It requires a lot of patience. You must wait to get results. And one of the ways you know it's working is when you have your baseline parameters. So, for example, you're training for facility, and you see that this patient is failing, the minus lens, for example, the -2 lens. After some time, when you've done your fluid lens raw, you've done your sorting, you've done your flipper trainings and all of that, you go back and check and see what he or she can do. That gives you the idea that it's working. And another thing I've also learned from, particularly in treating Vagen's problems, let's say strabismus to be precise, I learned that from Dr. Chendu back in the day. When a person comes to you and there's a deviation in the eye, just like we discussed yesterday about ARC, okay, the patient comes, the parent of that child will tell you, oh, I don't like where my child's eye is, and based on the stage that child came into your clinic, you will do all your assessment, measure all the parameters you need to measure, and you identify the few deficiencies in some of these systems, and you take note of them, because that's what will help you to build a therapy for them. Okay. So you finish all the therapy, you're able to build all of those deficient systems, but the eye is still deviated. So I learned something from him. He said that, and I think this is true. I know, not saying that I know it's true. If patient symptoms alleviates, okay, where that patient comes into you, tell you and tells you, I see double vision, I see this, I see that, and you have been able to help those areas of that patient, those key chief complaints or associated complaints that the patient got in, you have done your job. Even if that eye still looks deviated, you have done your job. So don't think that, oh, all the time when a tropic patient comes to you, the eye must be aligned. If you wait for that, you may wait for a long, long time. And if you wait for that to feel that you've done something for yourself, and then you may wait too long a time. So focus on the agenda. I'll call it agenda for lack of a better word. Focus on those key areas. In fact, you write them down and say this patient is in this. And if you're able to build that, you have done your job. It may not necessarily translate into realigning the eye, okay, because we know that sometimes for you to do that, then you are causing more problem for that patient, because you have to retrain the brain again to disregard the disconjugate retinal point, that it has been used to over time due to that deviation. And that's really a big deal for the brain. And if you do that, it means it has to get used to a new place, because the phobia now, this time around, is now alien to the brain, right? Because of that deviation, because it's using a disconjugate point on the retina. So I've said so much about this. I beg, let me stop. But the point is, don't think you're not doing enough. You may not see it immediately, but it's working, and it's truly working.
No, I think thank you, Dr. Osazee. The question Dr. Liven asks you're asking, is it that whether vision therapy works or not? Is that correct?
Not entire, not ambiguous like that. She didn't say vision therapy. Vision therapy works.
So
She asked
not whether
specifically for
therapy works.
problem.
I was asking for accommodative training.
Yes. Yes.
Accommodative training. That's the one I was really asking for, because that's the one I've done for Vangelis. Those ones they work. Like I've seen them work. But for native trainings, sometimes I just feel like I'm just
Yes,
receiving them as
no,
a
no,
patient.
no, the work, the work. The
Okay.
literature is there to support that. And even practical experience, I've managed a lot of cases, accommodative cases, and they really worked. So just like Dr. Osazee mentioned, all you need to do is to first of all identify the goals you want to achieve as you manage these patients, and you have to be patient and meticulous. So it's not something. Sometimes you might have a case of relapse, which happens if you're not careful in the way you follow up the case and in the counsel or advice you give to the patients or the caregivers. I mean, or the guardians in this case. So what they work, and we have a lot of evidence to support that they work.
Okay, thank
As you
you.
just mentioned,
Thank
thank
you,
you very
Dr.
much. You're welcome,
Okay,
Dr.
I
Lina.
think
As you
Dr.
mentioned,
Karachi wants.
okay, Dr. Please, before Dr. Karachi says something, I beg your pardon, please. Just 1 minute. As the NC mentioned about relapse, this is very key. You need, in fact, in my clinic, what I do, and I think I picked it from my boss back then, before you go into vision, I don't go into it anyhow because I know that I'm going to give him my time, I'm going to give him everything. Okay, so of course I charge you my charges for that is high on its own. So, but even with that, you must tell me, you must sign an agreement form that if you fail to do so and so, it's all written there. I'll give it to you. Go and read it for like 2 3 days and return it signed or not signed if you cannot meet up with the conditions. Because it's serious matter. You cannot spend the full time training someone and the person and there will be relapse. In fact, the brain is too complex to do that kind of a thing. You can't. As I said, it takes a lot of time, and um, each session have you don't go beyond a particular limit threshold. You don't go beyond it. Otherwise, you may even cause more problem for that patient. If you train beyond the capacity of that patient per time, you may worsen the case of that patient. So it's very intriguing. It's something that you must be meticulous, like the NC mentioned. You don't do it anyhow. You set goals for yourself. You give you the office therapy. If it's 1 hour, you do it. There are certain things you must do, and there are certain areas you must get to before you continue. So it's deep. It's deep, and you don't just do it anyhow. So they sign and all the terms and conditions are written there. You must sign, and if you breach it, so you're on your own. It's not my fault. You can't go and say that it did not work. You breached the agreement. So we can take a cue from that going forward. Thank you very much.
So let me jump in before Dr. Karachi comes in. I think one of the reasons some of us struggle to manage vision therapy cases is because we're not able to also assess from time to time. So for each of the visits, you should be able to assess to know the level of success you've had. And you should also, like Dr. Osazee mentioned, and I also highlighted, you should be able to have a way to evaluate your progress. That gives you an idea whether or not what you're doing is working and to keep track of what you are doing and what the patient is also doing. Otherwise, you keep doing the same thing every time, and you think you expect the results you want, but it won't come. So you have to really be meticulous and be detailed. So everything has to be detailed and meticulous for you to get what you want in vision therapy management.
Sure.
And I think for some cases that may require other care, other forms of care or therapy, maybe surgery, or case of high degree deviation and all of those things. But that may not be the focus of this class for today or this discussion. So, but we need to also be aware of them and what happens, the muscle recession and all of the things that happen in vision therapy, in managing deviations, large angle deviations, and what they do with the muscles. Dr. Karachi, over to you, ma. Sorry.
No problem. It's part of the upgrade. Thank you. Dr. Osazee, well done. I have two questions, just two little questions. First is on sight and vision. We are meant to understand that sight is what you see and vision is how you interpret what you see or how you judge what you see. Now, don't you think that vision has a lot to do with IQ? Supposing two patients that are emmetropes that seem very well, and maybe two drivers, and there's a bump or a ditch in front of them, the way the two drivers will navigate around that bump or pothole will be different, that their judgment will be different. Don't you think that that interpretation is based on IQ? Even when it has to do with some children in the class, they might be seeing very well, but the way they will interpret things will differ. That's question number one. Then my question number two is on accommodation. For some time, I think for several times, I've seen patients that are above biopic age, and yet they can read perfectly without any thing. Their we expected that their AA must have depleted at that stage. Yet when they were younger, they've not been myopic, nothing has, they don't have any visual problem. Yet, even in their 50s, some of them are still reading without it. I want to know, is it that they have accommodative excess, or it has anything to do with the accommodation? Thank you.
All right, thank you very much. When the fellow, I know Dr. Karachi is a fellow, I ask you a question, you must be very careful the way you answer it, and most especially when the person is very experienced. I'm humbled to answer this question, Dr. Karachi, and I think it's very straightforward in my opinion. The first question talks about IQ. Is it don't I think that IQ plays a role, that intelligence quotient now plays a role in the different responses of people as it concerns what they see? Now, the question I would ask, if you permit me to, is IQ is also a system that needs development. I'm sure you know that, except maybe we are talking about genetic, what's it called now? Genetic, the hereditary, genetical modulations and all of that. Because yes, over time, when we've seen that if a trait is repeated over and over in a generation, before you know it becomes part of that generation. You say, oh, from these people, this man's genetic line, they have very smart people there, people with IQ. Yes, I agree, because over time, when the genes, the character is replicated or repeated over and over again, there's a coding. The DNA is coded in that particular form, direction, and it's translated into the generation. I agree. However, we also know that IQ is based on exposure. Okay, outside the genetical etiology, it's also based on exposure. Look at this, like you gave this to a child, have two emmetropes, they don't have problem. Okay, now if one, for example, have a visual problem, let's forget about if one has a visual problem, whatever you're exposing both of them to, one of them will not appreciate it the way he or she should. And that's what we're looking at in this context. So outside the fact that there's a genetic interplay of IQ, there's also a large chunk of what that child is exposed to and how that child interprets what they are exposed to. It helps in IQ development as well. We can't shy away from that. So that's the area we should focus on. There's also a place, like I also mentioned, where someone is skilled You know, you can some children, in fact, most of the children that have this vision problem in this part of the world, they still learn. In fact, when I ask some of these parents that bring their children for care, how is the academic performance? When I find out that it's an binocular vision problem, I ask, how is the academic performance? Some of them will say, yeah, they are doing brilliantly well. And you're wondering, how is this child coping with all of this stress? Some children actually do a lot of work, you know, to still cope academically. All right. So we are not saying that all the vision, all poor adult children is due to vision problem. Even nutrition plays a role in IQ. There's a lot of things that plays a role in IQ, but our concern is the visual aspect, okay, of these children, how it works. There's a role of skill, there's a role of what you are exposed to, there's a whole lot of things, okay. So I don't know if I answered that your question, but we should be concerned about the visual aspect. There's no doubt that vision problems will not affect the patient's IQ. It will affect it because of the fact that IQ can also come or can be developed based on exposure, what this child is visually exposed to. Because learning, 80% of what we learn comes from our vision, particularly as children. We may hear things, but most of the things we see is what we learn from. And if they don't understand it the way they should, it will affect their intelligence and their quotient. The second question on accommodation. Yes, I've seen a couple also of patients that are above 40 and they still can read. They still can read. Just like you mentioned, two factors I always tell, but when I see that kind of a case, I ask first, were you a myope? Do you use glasses when you're younger? Some of them, based on ignorance, may not know that they had myopia when they were young. So I start explaining to them, oh, were you having difficulty seeing at distance? Some of them will say, oh, no wonder I don't see things at distance clearly. So yes, so that's why at this stage, at 50 years, at 50 something years, we still don't need glasses. That's one. Two, some patients is being self-denial because of the fact that because of this myth of wearing glasses, they just decide not to. I have a lot of them like that. In fact, very close friends of mine, some of them that are way above 40, they say they can still see. You know, they are denying the fact that they can't see. That's another side. Then another one that we should also rule out, they are Africans. Okay. There's also a spiritual connotation to that, where you know there's a miracle. At this age, I still can't read without class. I can read. In fact, in some part I heard, I don't know how true it is, in some congregation, because their papa don't wear glasses, you know, the general don't wear glasses. Any minister that goes there to wear glasses is as if you are denying the power of God. And so all of them, they will remove their glasses and they will come to the altar and start struggling to read. You know, I heard that. That's what I heard. I don't know how true it is anyway. But the truth is that sometimes you could have a miracle. I know that there's people who's 83 or 84 now. He doesn't wear glasses to read. And he never had, because he doesn't even wear glasses at all. He sees things at distance, he sees things at near. So we cannot also rule that out. So it's not because they have any accommodative problem per se, or it's also possible that, just like you mentioned, myopia may be existing and that's compensated for the presbyopia that they should experience at 40. And these are the factors. I don't know if I answered your questions, Mark. Sorry, I talked too much something.
Thank you.
Okay,
You're
Dr.
welcome.
Osazee, can I
Yes.
ask, or someone else wants to ask?
You are the moderator, Dr. Yedikachi. You
Wait
are
on us.
the
Also, wait now.
Okay, go ahead. No problem.
No,
Okay.
she's not a wait, so she's telling you whether to talk or not.
Oh, sorry, ma. Sorry, ma. Okay, should I talk?
From her.
Go ahead.
Okay, thank you, ma. Okay. I wanted to say, because concerning the site, and it's Dr. Karachi's question that just reminded me of this one concerning the site and the vision. For astigmatism, is it not a bit relative? Because there are some people with astigmatism, they can still be able to read. They can still be able to read the 6-5 vision, but symptoms now, like they have headache, they have discomfort, ocular discomfort sometimes, transient blood visions. That some of those signs are still present. So, but when they wear their glasses, when they wear their astigmatic, their cylindrical glasses, this problem is correct. So, for astigmatism now, will you categorize it strictly on sight? Would it be a bit relative? I'm a candidate.
Okay.
That's what I'm asking, because I'm a candidate for astigmatism. And I know
Okay,
I
that
can
question.
actually wear my glasses sometimes, but sometimes when I start having the symptoms, I feel much better wearing my glasses. All the myopia and all that clears off with my glasses.
Okay. Can I answer that?
Yes, sir.
All right. So, well, it's basically astigmatism from its definition is a refractive error, and a refractive error is has to do with solely with the ocular, I mean, within the eyeball itself. Okay, so rays are not properly focused, because of the unevenness um, of the media, either the cornea, lens, or even the axia of that retinal, but we also have a retinal astigmatism. All right, so it's not a vision problem because this person is actually not seeing that. They may interpret it wrongly. I was thinking you would say it's interpretation because a typical astigmat, outside the symptoms they experience now, will call you, they will call it maybe T. So they misinterpret, the letters they see. Yes, because of the skewness. Astigmats don't really see blurriness except maybe it's high degree. What they see the thing, but it's distorted because of the unevenness of the curvature of the refractive surface. So they see it's distorted. So they may call a D an M or something like that. Okay. But the whole idea is that it's still a refractive problem. You cannot take it out. All right. And anything refractive is a sight thing because we said that sight just involves the eye. Okay. It doesn't move from there to the brain. Although the patient may, just like I said, the question may be, okay, but they interpret it wrongly. The brain interpreted wrongly. It's not the brain that does this now. It is what is imaged from the brain. What is imaged from the eye to the brain is already wrong at that point. So the brain just calls it whatever it wants to call it. So it's still basically a sight thing.
Okay, thank you. I just read Dr. Cynthia's chat. She said I was in her mind, so I wasn't thinking alone. She was thinking the same thing too. She typed the same question. So it's okay.
Yeah.
Thank you, sir. Thank you.
The second, I want to believe that was what you put in your pre-test too.
I put the two of them now. I put the two of them. I put vision attack because I felt it's relative. So it's okay. No problem.
Okay. Thank you very much, ma. This is 19 past 10. Tomorrow is work. So
Dr. Osazee, please, the astigmatism that we're talking about, can we also consider the fact that if it depends on the degree of astigmatism. If the astigmatism is mild, let me use that word as it were, the eye muscles can compensate, and that is where the complaint starts. But if you have a significant astigmatism, there's nothing the person will do. Vision will form, sight, let me say, visual acuity will be poor, unless the person is given the glasses. So just like in hyperopia, which is a refractive error, a hyperope can see, but you see at the expense of the effort of the muscles to be able to bring those two images to one.
The same thing with astigmatism, if it is little, as it were. Pardon my non-doctorish term, as it were now. So, but once you refract and give the person his or her refractive correction or compensation, that is gone. The same thing with astigmatism. So if we want to classify astigmatism as vision, it's basically a refractive error, because once it is significant, just like if you have a significant hyperopia, the patient has poor vision at both distant and near. The same thing with astigmatism that is significant. But once you refract and give the person his refractive compensation, the person sees well. So let's look at this, classifying it into a vision problem again. Thank you.
Okay, if I get it correctly, are you of the opinion that it should be a vision problem or a sight
No,
problem?
it's a sight problem according to
the sight problem.
All right, thank you.
It's a sight problem.
Okay, so Dr. Osazee, let me ask my own so that we can round up the. So we know binocular vision dysfunction is beyond accommodation and vergence, right? According to your definition, you said anything that anything that can cause the brain not to fuse two images from the two eyes can lead to binocular dysfunction. Now, I want to ask, when there is a problem in the visual pathway, as it is not as a result of accommodation or convergence, but this time around, a problem in the visual pathway, what is the presentation? How is it going to look like? And what is the role of an optometrist in that case?
This is a very deep question. In fact, I remember in my getting my fellowship in the academy, one of my cases discussed this because I submitted one of my amblyoptic cases that I treated, and this issue came up when we talked about deprivation. Sorry, I'm using that scenario to explain this. When we talked about deprivation and amblyopia, I was of the opinion that, of course, deprivation of amblyopia is when there's a blockage in the pathway of light to the eye. And based on my reading and based on my understanding, I also believe that even from the eye to the brain, there's also a hindrance or a blockage of impulses from the brain from the eye to the brain, not necessarily now from objects to the eye, but from the eye now to that's the visual pathway itself. If there's an obstruction, it can also be termed as amblyopia. And that's the only line was one of the reasons, in fact, was the major reason they rejected that case. That case did not pass because I felt deprivation. We are depriving the brain from having the right information, so it will not pass. But it was much later when I did a lot of research, I came to find out the difference between organic lesion and inorganic lesion, basically. So if there's a lesion naturally in the brain, okay, we don't call that. In fact, it's not a vision thing anymore now because it's just like you say someone that has a mental problem. Okay, something is happening in the brain that makes this person a mad person. Is not it's not visually related. It's something that has to do with the brain. Okay, how the brain. So okay, a stroke. Someone that has stroke. Okay, it's also a brain problem. There are a lot of brain conditions that we will not associate with vision, and that's exactly what it is. So when there's a problem in the visual pathway, we don't call that it's not a vision related thing. Okay, it's not a vision problem in itself, but now it has gone to the higher centers, and it's best we call it an organic lesion, whereby this is due to a problem in the brain, not something that is vision related. Because if it is vision related, then it should be that the pathway is clear. We don't have any vision, we don't have any problem there. What we're having is the ability for the brain to interpret correctly what the eye is sending as sensory, and of course how the brain is returning back these impulses to the muscle for interpretation and all of that. But if we have a problem in that regard, then it is regarded as a vision problem. But when there's an organic lesion, it defies that definition. I don't know if it's clear, Dr.
Okay, very well. Yeah. Thank you.
Thank you.
Okay.
Dr.
So, Dr.
Osazee, how would you differentiate, or can you
Organic
explain if they're the same? If sustained accommodation and accumulative inertia.
Okay. Just like I explained earlier, okay, ill sustained, okay, talks about when there's accommodation, okay, it presents itself at the beginning, but after some time, okay, it fails. Okay, you get my point? It fails because you cannot sustain it. It fails
After
after some
repeated
time.
effort. Yeah, that's correct.
Exactly. It fails after some time. It's a very straightforward thing. You can't miss it out at all. It fails after repeated stimulation. Okay. Now, but inertia has to do with a drag. You know, when you hear that word inertia, there's a drag. There's something delaying it, okay, from responding. Okay. I think inertia is also called facility. In facility, if I'm not mixing it up now, because in facility, what you have is a delayed response to accommodation. Okay. So inertia now, accommodative inertia is when there's a drag, there's a delay before accommodation kicks off. But this time around, you have it. It's not about matter of it's kicking off. In ill sustained, from the very beginning, it's there. So with repeated stimulation, with constant reading, after some time, it gives up. But in inertia, it's to respond in the first place is a problem. So these are the differences. I don't know if that's clear.
So is inertia the same as infacility then?
I think so. Some materials cause it infacility. Yes, some material cause it infacility. I think that's because the explanation, permit me, I don't usually cram words, but I understand concepts, okay? And that helps me a lot to remember some things. So inertia there talks about delay. And yes, infacility is also inertia because in infacility, what happens is a delay for accommodation to either relax or be stimulated based on the distance.
Yeah.
So yes.
That's correct. Because that was one of the questions I was asked during the fellowship defense. Yeah. So we need to get them right. So inertia is the same thing as the infacility because you have the drag, sluggish. So when you look at something at far, typically, and you want to come to look at something at near, it blurs. Conversely, if you look at something at near and you want to change your focus to something at far, it blurs out again. So that's sluggish response at far and near. So you see children copying and when they look at the board to copy and look at their paper blanks out. It will take a while for them to clear the paper again, their book to write. And that happens repeatedly. Okay, just another question. I think that's far from the question on the presentation. Was the delay in having the result from Dr. Priscilla? Have you followed up with her? And that of yesterday, I know that of yesterday is still early, but the one before yesterday.
Okay, she has sent it to me. She sent it to me. I directed her to send it to Dr. Cynthia. Dr. Cynthia, you're here, right? Let me see. Oh, okay, because Dr. Cynthia is actually the moderator for that day, and Dr. Cynthia took the attendance. But why it's delaying is she sent it, I think her scoring formula was not correct. She scored everybody over 100 based on those pre-tests and post-tests. So I told her that no, she needs to give the awarded the allocated marks to each of those components. So there's attendance, there's active participation, pre-test is just 20%, and post-test is 60%. So that was the conversation we had. She actually set it to the end of this. So I had to tell her to do those corrections and forward it to Dr. Cynthia so that she can fill it in our score sheet and post it on the platform. But I think she has
It
So
will be
Dr.
useful.
Cynthia,
It will be useful to send us our individual results as well and
okay,
feedback
that's true.
if it's necessary.
I failed to mention it to her.
Yes,
Okay, I would also do that.
we
Yeah,
need to
I would
get the
also do
feedback
that.
from her.
Yes. Although she actually sent the answer to the platform so that we'll know if we got it or not. Dr. Cynthia, she contacted you. Dr.
Not
Cynthia, are you
yet.
there?
I'm
Oh,
here.
not yet.
Not
Okay, ma'am. But you took attendance that day, right? Because I don't have it. I don't have the attendance for that day.
I did.
But actually,
I took attendance.
yes. All right. Thank you very much.
Can you hear me?
So the post,
Oh my.
yes, I heard you. Cynthia. I heard you. The
Okay,
network can be frustrating. I heard you.
okay. I think Dr.
Okay.
Osazee, you sent the posters, right?
I have, yes, I have.
Okay. Maybe
So I was
you give us
expecting.
till 11.
Please, I have a complaint. This I don't know if you can hear me. These
Yes,
seminars that I saw, like this one that said Dr. Onedikachi screenshot and posted on the page. I've been on this lecture from start to finish. It's just that my network will take me up, take me in. And the time you will now screenshot, you will see that the person is not there. You say the person is not part of the lecture. They should find a way to fine-tune that, because there is no way I was not part of the lecture, or other people will not be part of the lecture till the end. Because when you screenshot that, now my name is not there. At the end of the day, people will give me 1% as my score, which will not be fair to one concern. I'm just speaking
No,
for.
Dr. Cynthia, see your name. I screenshot
I
the
have
one
a
that you
big
had your
network
name.
I have a big network challenge, and I've complained that to Dr. Osazee so many times. I'm just speaking
yes,
for my.
yes.
Thank you.
No, you are very correct.
See
Please,
the second post. Your name is there. I captured your name.
yes, Dr. Edikachi, please, let's consider her. I know each time, because there's a tone that if you're coming and go out, there's a tone my Zoom app usually gives. So I know each time I hear that, I know Dr. Cynthia has been taken out. It's now part of my consciousness. So I know she's making a lot of effort to join in, but unfortunately her network is poor. So for her, I know she usually comes in for attendance. So Dr. Cynthia, sorry, you are covered. We understand that. It's not your fault.
Thank you, sir.
Okay.
You're welcome, ma'am.
Okay, I think in absence of any other business, we've come to the end of today's presentation. Thank you so much, Dr. Osazee. I don't
Thank
know
you
if you
very
have
much.
any word from our NC before we call it a day.
No, I
When
think
are we
it's a good
submitting the post test?
By 11, or Dr. Osazee, right? Before
Yes,
on or
yes.
before 11?
After 11 p.m., it will no longer be considered.
Okay.
Before 11.
So why 11 today?
You are the one that gave us 1 hour yesterday now.
No. That was different. That was different because
Okay. No, because right now, me, I have not even started answering the question
I
because
just saw it now. I
my
just saw it now. I
concentration
didn't know
is
it has
there.
posted. I just saw it now.
So it's after now
Although
that I was.
it's actually very cheap. It's the same as your pre-test, just 2 other questions were added. So, but let's just give and take.
it's okay. If all of us are okay by that, it's okay. It's okay.
Because
All right.
network can also like Dr. Cynthia's network.
Okay. Who is presenting tomorrow, Dr. Osazee? And what module?
Tomorrow is ophthalmic lens dispensing, if I'm not mistaken. And
Is that Dr.
it's
Hardy?
supposed to be taken Hardy, yes.
Is
But
he going
if
to be
he's not
presenting
available,
tomorrow? We've not seen him
but
attend since.
exactly, I don't see the possibility of that based on the fact that he has not
So
been around.
can you communicate to us before 10 o'clock tomorrow so we'll be aware of what is going on?
I've said it would miss any day. So even if he's not ready, someone will take his place. Just like
Okay.
I did today with Dr. Daffy. Someone will take his place. So we don't want to stop.
Okay. I think it would be nice to sort it out so we're aware, we're sure what is going on tomorrow.
It's all right, sir.
Yeah.
No problem.
All right. Thank you, Dr. Osazee, and good night, everyone. We'll meet again
Thank you,
tomorrow.
everyone.
Good night, everyone.
Night all.
Good night, all.